Hello everyone and welcome to our second module on heart failure. In this module we're going to talk about the treatment of heart failure, and when you're treating heart failure you really have to decide whether you're treating acute heart failure or chronic heart failure. Patients with acute heart failure are volume overloaded. In the first video on heart failure I talk about how to assess a patient's volume status, and patients who are volume overloaded have pulmonary rales and lower extremity edema and elevated jugular venous pressure. Patients with heart failure who are volume overloaded are in acute heart failure, and your goal for treatment of these patients is to improve their symptoms. You want their dyspnea to get better, you want their pulmonary congestion to improve. Patients in chronic heart failure are euvolemic on exam, so they no longer have rales, they no longer have edema, but these people still have a heart condition and they're at very high risk of being hospitalized or dying from heart failure. So the goal in treating chronic heart failure is not to improve symptoms because patients are already euvolemic. The goal is to prevent things like hospitalizations and mortality from heart failure. The goal of treatment of acute heart failure is to improve symptoms, and the way this is done is by giving drugs that reduce the left atrial pressure and remove fluid from the body. Remember that patients in acute heart failure have a high left atrial pressure, and that causes pulmonary edema and dyspnea. They also have excess fluid on the body generally, which causes pulmonary edema as well as lower extremity edema. The most commonly used class of drugs to achieve this goal is the loop diuretics. Drugs in this class include furosemide, torsemide, and also sometimes bumetanide. All of these drugs inhibit the sodium-potassium 2-chloride pump in the ascending limb of the loop of Henle. This causes more sodium to go out of the nephron and it takes water with it, and that relieves congestion generally in the body. When you administer these drugs, the urine output will go up and the intracardiac pressures like the left atrial pressure will fall. This is going to improve pulmonary edema and also improve the lower extremity edema. The major adverse effect of these drugs that you have to worry about clinically is hypokalemia. So in any patient in the hospital receiving loop diuretics, you need to check the electrolytes every day and monitor the potassium and replace potassium as indicated. Other adverse effects that can occur: these drugs reduce the glomerular filtration rate by lowering the total body fluid, and that can cause acute renal failure. Also, because they remove fluid from the body, they can potentially cause volume depletion and hypotension. And then a last point I should mention, because they will ask you about this on your board exams, in addition to increasing urine output, these drugs also cause a mild degree of venous dilation. When the veins dilate, blood pools in the venous system, and this pulls blood away from the heart and lowers the left atrial pressure. This is similar to the mechanism of nitroglycerin. And because of this effect, when you administer loop diuretics, there's an immediate improvement in the patient's breathing even before the urine output increases. Eventually the urine output will pick up, and that's going to help the patient's symptoms, but the immediate relief of symptoms comes from this mechanism here of venous dilation. So loop diuretics are the main way that acute heart failure is treated. That's what you'll most commonly see on clinical rotations, but there are some other drugs that are used less commonly. One of those is nitroglycerin. This causes the veins to dilate so that blood pools in the venous system. This will reduce the left atrial pressure and lower the preload, and this can improve dyspnea. We also sometimes use afterload reducers. These are drugs like hydralazine and ACE inhibitors. They cause dilation of arterioles, and that lowers the afterload and increases the cardiac output. This can improve the perfusion of the kidneys and lead to diuresis. So sometimes, especially in patients who are hypertensive with heart failure, these drugs are used to generate a diuresis. So once your patients are treated with loop diuretics and they're feeling better and they go home from the hospital, they still have heart failure. They're no longer in acute heart failure, but now they have chronic heart failure. And in this stage of treatment, we want to administer drugs that improve prognosis over the long term. For patients who have diastolic heart failure or heart failure with preserved ejection fraction, there are no specific therapies for chronic heart failure. What we do for these people is we control their blood pressure, we keep their blood sugar normal. We sometimes give them diuretics chronically to keep their volume status normal with drugs like furosemide, but there really aren't any drugs that have been shown to improve outcomes over the long term for patients with HFpEF. Patients with systolic heart failure with reduced ejection fraction, are totally different. For patients who have HFrEF, there are lots of specific therapies that have been shown to reduce the rate of hospitalizations from heart failure and lower the mortality rate. So in these patients who have HFrEF, we give them lots of treatments, all aimed at preventing the progression of their cardiomyopathy and the return of symptomatic systolic heart failure. So remember, the goal of treatment of chronic systolic heart failure is to reduce the rate of hospitalizations and mortality. These patients feel well, you've improved their breathing, so you can't make their symptoms better necessarily, but you can prevent them from getting worse and coming back in the hospital. And the way this is done is by using drugs that are referred to as GDMT. GDMT
means guideline-directed medical treatment. All of the drugs shown here on this slide have been shown to improve outcomes for patients with chronic systolic heart failure. First class of drugs is the beta blockers. We use metoprolol, carvedilol, or bisoprolol. All three of these beta blockers have been shown to improve outcomes in systolic heart failure. ACE inhibitors have been shown to improve outcomes in systolic heart failure. These are drugs like captopril and lisinopril. Aldosterone antagonists are used in systolic heart failure. These are drugs like spironolactone and eplerenone. There is one neprilysin inhibitor. It's called sacubitril. It boosts the ANP level. And then, as we talked about before, ANP leads to diuresis and counteracts the RAS system. Ivabradine is a drug that inhibits the SA node and slows the heart rate. This is used in a minority of patients with systolic heart failure. And finally, the combination of nitrates and hydralazine has been shown to improve outcomes in some patients with heart failure. So all of these drugs, or these groups of drugs, can potentially be administered over the long term to patients with chronic systolic heart failure, and these will reduce the risk of hospitalization and mortality from systolic heart failure. Most of these drugs work by disrupting the chronic activation of the sympathetic nervous system and the RAS. By doing this, you prevent a process known as cardiac remodeling, which basically just means progression of left ventricular dysfunction. If you leave systolic heart failure untreated, patients' cardiomyopathy gets worse and worse over time and the left ventricular function falls over time. If you administer these drugs, that is less likely to occur. Besides the drugs of GDMT, there are a couple of devices that can be surgically implanted in patients with systolic heart failure to improve outcomes. The first device is called an ICD, or an implantable cardiac defibrillator. So the annual risk of sudden cardiac death is greater than 20% in some studies among patients with systolic heart failure. Most of these sudden cardiac deaths are due to ventricular tachycardia, and this is an ECG tracing of ventricular tachycardia shown on the screen here. So an ICD is a small device. You can see a picture of one here. It fits in the palm of your hands. It's surgically implanted with a wire to the heart, and it monitors the heart rhythm. And if it detects ventricular tachycardia, it will deliver an electrical shock to try and terminate the arrhythmia. And we use ICDs in patients who have systolic heart failure in a couple of situations. If they have systolic heart failure and they have survived a sudden cardiac death, in other words, if they had survived a cardiac arrest, those patients always get an ICD. And then most patients with a left ventricular ejection fraction less than 35% are potential candidates for an ICD. The second surgically implanted device that can be used in patients with systolic heart failure is called a biventricular pacemaker. It's also sometimes called cardiac resynchronization therapy, or CRT. If you look at these two echocardiograms on the screen here, on the left side is a patient who has a left bundle branch block, and hopefully you can appreciate that the contraction of the walls is out of sync, meaning when one wall comes in, the other wall is going out, and vice versa. After placement of a biventricular pacemaker, you get the result shown on the right side of the screen. Now the walls are contracting in sync, and this improves the left ventricular function, and studies have shown it also reduces the risk of death and hospitalization from systolic heart failure. So biventricular pacemakers are also a small device that fits in the palm of your hand. They also have wires that connect to the heart, and they improve mortality in appropriate patients. If you choose patients correctly for this device, they are less likely to die from systolic heart failure. For a patient to be a candidate for a biventricular pacemaker, they must have a reduced left ventricular ejection fraction below 35%, and they must have a left bundle branch block. If you look at this EKG on the screen, this is an example of a left bundle branch block. I've zoomed in on lead V1 on the right. It has a QRS width that is prolonged, greater than 120 milliseconds, and that is always seen in patients with left bundle branch block. And there is a downward QRS complex in lead V1 that is also the hallmark of a left bundle branch block. So here's just a quick summary slide to review the treatment of heart failure. Patients who have acute heart failure need drugs like furosemide or nitroglycerin or afterload reducers, and the goal here is to remove volume from the body and improve symptoms. Once patients feel better, if they have a normal left ventricular ejection fraction, they have diastolic heart failure, and there are no specific therapies used over the long term to reduce adverse outcomes. In contrast, if they have a reduced left ventricular ejection fraction in systolic heart failure, then we use the drugs like GDMT that we talked about, and you can also consider an ICD or a biventricular pacemaker. A special category of heart failure patients are patients who have what's known as advanced heart failure. These patients have a severe form of systolic heart failure or heart failure with reduced ejection fraction. And by severe, I mean that the cardiac output is severely reduced to the point that the patient can have fatigue, chronic hypotension, cool extremities, the brain can be underperfused leading to confusion, and they can have poor appetite from underperfusion of the gut. This is called cardiac cachexia because these patients can lose weight and become very undernourished. This is a subset of patients with systolic heart failure, but there are some special treatments only used in the case of advanced heart failure. The special treatments are listed on this slide. The first one is inotropes. These are drugs that increase the cardiac output. Dobutamine is a beta-1 agonist, milrinone is a phosphodiesterase inhibitor, and digoxin is an oral drug which inhibits the sodium-potassium ATPase. All three of these drugs will increase the cardiac output. You should be aware, however, that they're not routinely used. That's because in studies of the routine use of these therapies in patients with systolic heart failure, there was an increase in mortality. So we reserve these drugs only for patients with advanced heart failure and the symptoms I talked about in the last slide. Other options for patients with advanced heart failure are left ventricular assist devices, which are mechanical heart pumps implanted surgically, and finally heart transplantation. Heart failure is a chronic condition with acute exacerbation, so patients with heart failure will feel well for a while and then develop dyspnea and lower extremity edema, and you'll treat them and then they'll feel well for a while and then again develop symptoms. So let's talk about the causes of these acute exacerbations. The top two causes are dietary indiscretion and poor medication compliance. If patients with heart failure consume a lot of salt, for example, there's lots of salt in burgers and fries like shown on the screen here, they will retain fluid to match that sodium intake, and this will lead to congestion. So many patients who acutely develop symptoms of heart failure, it happens because they went out to a restaurant and ate a salty meal. The second most common reason is poor medication compliance. As we saw when we looked at the list of meds in GDMT, there's lots of pills that heart failure patients have to take. It's often very difficult to take these correctly. Patients can run out of medicine. So poor compliance with the complex medical regimens for heart failure often leads to an exacerbation. Shown on this slide are some less common causes of acute exacerbations. Patients who have an infection or who've had trauma or who just had surgery have activation of the sympathetic nervous system, and this leads to retention of sodium in water, and that can cause an acute exacerbation of heart failure. Ischemia is a rare cause of heart failure. If you have a myocardial infarction, this can lower your cardiac output, and that can lead to heart failure. Patients with heart failure who develop an arrhythmia, like the onset of atrial fibrillation, can go into heart failure. And then finally, nonsteroidal anti-inflammatory drugs are a famous cause of heart failure exacerbations. These drugs inhibit the enzyme cyclooxygenase, which produces prostaglandins, so patients taking these drugs have underproduction of prostaglandins. And prostaglandins are very important for maintaining renal perfusion. Patients who take NSAIDs can have a decrease in the renal perfusion. This can lead to the retention of salt and water, and that can trigger a heart failure exacerbation. So here's a typical acute heart failure course like you might see in the hospital. A patient presents to the emergency room with dyspnea, edema. They're sleeping in a chair because they can't breathe lying flat. They're admitted to the hospital. They're given a nitroglycerin drip to relieve dyspnea. They're also administered intravenous furosemide to remove fluid. On the second hospital day, their weight is down 4 kilograms and they feel better. The nitro drip is stopped. They're changed to oral furosemide, and at hospital day 3, they're discharged home. At this point, they have chronic heart failure, and the subsequent treatment for the long term will depend on whether they have diastolic or systolic heart failure. A more complex heart failure course for a patient with advanced heart failure might look like this. Patient comes to the ED with symptoms of heart failure. They have a known left ventricular ejection fraction that is very low at 10%. They're admitted to the hospital and given a nitro drip and furosemide, but on the second hospital day, they have poor urine output, their extremities are cool, and their creatinine rises, indicating underperfusion of the kidneys. At this point, a dobutamine drip is started to improve the cardiac output. Over the next few days, their urine output improves, they lose weight, they feel better. On hospital day 6, the dobutamine drip is stopped and the furosemide drip is stopped. They're discharged on oral furosemide and they go home to follow up in heart failure clinic. And this is a description of a patient with advanced heart failure, so you know they have a reduced ejection fraction, and this patient is going to need long-term GDMT in consideration for treatments like a defibrillator and a biventricular pacemaker. I'll finish this video with a couple of high-yield odds and ends related to heart failure, and the first one is non-invasive ventilation. If you look at this woman on the screen here, she is hooked up to a ventilator. She's hooked up to a mechanical breathing machine, but she does not have a tube in her trachea. Instead, there's a mask that is sealed to her face and it's forcing air into her lungs. This is called non-invasive ventilation, also known as positive pressure ventilation. It's ventilation from a ventilator administered through a mask, not an endotracheal tube. And this is commonly used, especially in the emergency room, in patients who have acute respiratory failure, and it's especially effective for pulmonary edema. And in many patients with acute heart failure who have respiratory distress, if you place them on non-invasive ventilation, they will feel better and you can avoid intubating them. Now, a couple of asides here. Patients have to be awake, alert, and cooperative, so non-invasive ventilation cannot be used on someone who is lethargic or unresponsive. So a classic case is a heart failure patient in respiratory distress. They're tachypnic, they have hypoxemia, You place them in non-invasive ventilation and they have improved respiratory status, and then you can administer furosemide and other drugs to try and improve them for the long term. Let's talk about functional mitral regurgitation. It's called functional because it's caused by the function of the mitral valve, not an anatomic abnormality of the valve. The cause of functional mitral regurgitation is left ventricular dilatation. When the left ventricle is dilated and engorged in acute heart failure, the mitral valve leaflets can be pulled apart, and this can lead to what's known as functional mitral regurgitation. It will cause a typical murmur of mitral regurgitation, which is a holosystolic murmur at the cardiac apex, and it often resolves with diuresis. So in a board question, for patients in acute heart failure with moderate mitral regurgitation, don't choose to send them to surgery. Choose the answer that is diuresis. That will improve the left ventricular function and allow the mitral valve to function normally, and it may make the mitral regurgitation go away or become less severe. Hyponatremia is common in patients with heart failure. You should be aware of this. When the RAS is activated, this leads to release of ADH from the pituitary, and that causes water retention. In addition, patients with heart failure often have poor renal perfusion from low cardiac output, and this leads to decreased water excretion. And you should be aware that many clinical trials have shown that the presence of hyponatremia is a poor prognostic indicator. If they describe a patient in a board question with hyponatremia and heart failure, that patient has a poor prognosis. On your clinical rotations, you will see many patients who have pitting edema, like shown in this picture here. The vast majority of those patients do not have heart failure. They have a condition called venous stasis edema. This is very common in the elderly, and it's caused by poor venous drainage from the lower extremities, basically blood pools due to gravity in the lower extremities, and that leads to pitting edema as is shown here. This has nothing to do with the heart. These patients do not have dyspnea, they have a normal lung exam, they have normal jugular venous pressure. Their only clinical finding is lower extremity pitting edema. The treatment is to elevate the legs as much as possible. You can wear compression stockings which push fluid out of the legs. Diuretics are usually not used because they rarely work. And in general, this condition is more of a nuisance and an inconvenience. It's not particularly dangerous. The only exception is if it goes on untreated for a long period of time, the skin can start to break down and patients can develop skin ulcers and infections.
I'll finish with a super high yield topic, drugs that you want to avoid in patients who have heart failure. First drug is metformin. This is a diabetes drug and it's associated with lactic acidosis. And most cases of lactic acidosis occur in patients who have renal failure or heart failure, so it's generally avoided in patients who have significant heart failure. A second group of diabetes drugs that are usually avoided in heart failure are the thiazolidinediones, otherwise known as the glitazones. These drugs have names that end in glitazone, like pioglitazone or rosiglitazone, and these drugs are avoided because they can cause fluid retention. Calcium channel blockers, especially verapamil and diltiazem, are avoided in systolic heart failure because they are negative inotropes and can further reduce the cardiac output. And then lastly, NSAIDs are generally avoided in heart failure because they decrease blood flow to the kidneys and cause fluid retention and can potentially trigger pulmonary edema. And that concludes our second video on heart failure.